Eh bien, bonjour et bienvenue pour
Hello everyone and welcome for this session entitled Environmental Policies and Public Health in the Regions, with a presentation Preserving the Health of Today and Tomorrow's Generations. My name is Pascal Giana. I work for Santé Publique France and I work for many years for the Regional Healthcare Agency of my region, and I'm going to moderate with Valérie Henry and Jean Simos, who's speaking from Geneva and who's a research lecturer from the University of Genève. When we prepared this session with Valérie, what seemed interesting for us was to go back to a concept that was important to interlink environmental policies and health policies, namely health-friendly urban planning. This is what we mentioned yesterday within the concept One Health, as well as the integration of this in all policies. The aim is to try to understand with illustrations how we can go from the concept of health-friendly urban planning to reality. What do we concretely need to move forward on the ground? The scope of determinants of health-friendly urban planning is very large, so we try to focus on nutrition and physical activity to be more eloquent on the different speeches that we will present. So first, we will see the importance of having evidence, probative data, and how we can put this into perspective to underpin advocacy on a health-friendly urban planning. And we'll speak with Jean, who's a lecturer at the University of Arts et Métiers, at the School of Arts et Métiers, and he will talk about the benefits of walking and cycling and how it can be used by decision makers to establish ecological transition policies. Then we'll speak with, we'll have Jacqueline Renaud from Rhône-Alpes, Valérie Parron, and we'll talk about the interests and benefits from a regional healthcare agency of a health-friendly urban environment. We'll talk about health KPIs that are unfavorable for overweight, for obesity, and what kind of measures we can implement in neighborhoods to favor physical fitness, how we can have urban policy in neighborhoods, and how we can change individual and collective behaviors. This we'll see with Diane Bayeux, who will talk about the Camellia Santé project. She's a dietitian and she works at the Mutualité from La Réunion. Then we'll have a small coffee break and we will resume with Yannick Nadezan. He is a member of the Réseau Français Ville Santé, the French Healthy Cities Network, and he will talk about the WHO project, where we stand now, how it has evolved, and how they help cities in the setting up of good practices for health-conducing policies. Then we'll talk about an agile engineering to take into account all the social health urban planning policies for the UFS to have sustainable policies. We'll have Brice Van Aren, who will talk about an urban planning agency, in this case the Strasbourg one, how they can actually use this concept of French healthy cities into their public policies. And then we have Mrs. Weber, who will talk about her experience with an ambitious project in Utrecht. And that will allow us to see that HUP is not utopia, and we can have a city that will stand for well-being. And this lady is actually talking about the city of Utrecht. And then we'll have a conclusion. So we'll have a discussion to talk about everything that was said during the afternoon. And as a wrap-up of this introduction, I'll give the floor to Valérie first, and then to Jean Simos, who will make an introduction on HUP, Health-Friendly Urban Planning. So just a few words from me to thank, first of all the speakers with whom we've been working for several weeks, several months. Thank you. Some of you come very far, far away, and your attendance and input will certainly shed interesting light on the subject. We would like to thank Anne-Julie Axeri from the PPS, who helped us a great deal, and Manti Pascal, who also gave us a lot of tips, useful tips. And I would like to thank Pascal Janin, because without him, this session would not exist. I could not do anything without him. So thank you. A round of applause to all of them. And now we'll give the floor to Jean. You have the floor, Jean. Hello, can you hear me? Very good. Can you see me? Not at all. Well, there seems to be a small technical glitch, so I'll be only a voice. Hopefully the image will come along afterwards. For 12 minutes approximately, I will make an introduction to the issue of the session. Could we have the slide on? Yes? Yeah, we see it. I can't see it, unfortunately. You're on the second slide here. An increasingly urban world. No, I can't see anything. So,
ok, ça c'est le début, merci.
That's the beginning.
Je vais regarder en fait sur mon PowerPoint.
I will look at my PowerPoint.
Je demanderai les diapositives d'échanger.
And I will ask the text to change the slides. So slide 2. Thank you.
Vous me dites juste parce que
so,
je peux pas
please tell me, because I can't see at once.
Que je jongle entre les deux.
I have to juggle between the two. Is it displayed? Yes, you can. You can trust us.
Voilà, donc c'est ce que la première, enfin, le point de départ, c'est
so that's the starting point. Namely, we live in an increasingly urban world. At the beginning of the previous century, only a third of the humanity lived in an urban world, versus 2/3 in rural areas. And only in developed countries did we have a majority living in urban areas. Currently, we stand at 56% of the world that lives in urban areas or towns. The shift took place in 2008. And the forecast for 2050 should reach more than 2/3, where we would actually reverse the previous situation, and we would have 2/3 living in urban areas. So we have to see what kind of relationship we have between urban living and health. What we can see as a first stage, there are 3 stages for the relationship existing between urban living and health. First of all, an important stage, especially for health and environment purposes, we need sanitation. This has shaped also our living environment an urban environment. You very well know what happened during the 19th century with the major works. We go from the Middle Ages to having apartments with more light coming in, for instance. This is part of the sanitation and hygiene works. And then the second stage is a matter of functionalism. This is characterized by the Charter of Athens, dealing with how we would see the allocation of a city by function, by neighborhood. But there's a link, namely combustion engine motor vehicles. And this is something that we see and we see the consequence that it has on health. The third stage that we have now, can we have the third stage, please? Which is sustainability, that I will show you at the end of the last century with the Ottawa Charter, the Healthy Cities program that we will mention this afternoon, and the Sustainable Development, the Agenda 2030, the SDGs, and the 9th World Conference on Health that took place in 2016 with the Shanghai Declaration and the Mayor's Consensus. So if we go back to the second stage, namely that dealing with functionalism, shall we have this? What is important is the matter of urban sprawl, because with the immediate availability with the car, we try to go further because we have a car to go to a healthier environment, which led to a low population density with a sprawl. We have housing spread over large plots of land and a low functional mix. We have residence places that are far away from school or from hobby or from leisure venues, and so we can cover greater distances to go from one place to another, and we can focus on automobile infrastructures that bring you to different places, but also separate communities with different types of urban development, which entails social segregation. And this, because we give priority to cars, means that we have less and less pedestrian infrastructures or cycling infrastructures and so on. The main impact of this urban sprawl is physical inactivity, and it has an impact on health. It can be both direct and indirect. Here you have a graph where we see the share of disability addressed in life years, which gives us a good measurement of mortality, but morbidity as well. And it gives us the idea of the disease burden. We can see what smoking, risky alcohol consumption entail. We also see physical inactivity as a sixth position, but there are other factors which are just as important, like overweight. With overweight, we have the problems of nutrition, and also the insufficient consumption of fruit and vegetables. This is the last in the last position, but we can see also high blood pressure, illegal drugs. So we see that sedentary lifestyle can have an important impact on our health. And we can have also dyslipidemia. So, at the beginning of the 21st century, we find that there are contextual factors that are associated with obesity. In our urban context, we can see them in a straightforward way here on this survey dating back to 10 years ago, approximately, which illustrates the correlation between the other factors, the socioeconomic level. We know that there's a social gradient, but also the average distance to convenience stores, and also having a proportion of fast food restaurants within a 500-meter radius close to our housing, like in New York. We try to avoid having fast food restaurants in the underprivileged neighborhoods and having also shops nearby. Then, we also said there was a relationship between environmental issues and social issues, and we can see it here with the link with the social inequalities. We can see it in terms of weight inequalities. If we look at this graph, we can see three important components. First, the food offer. That's everything that is available and accessible in our society. Then on the right-hand side, we have the social environment with social class categories, living conditions, working conditions, access to transport, isolation, social links and networks, eating habits, social and cultural norms. And then we also see in the middle this link between the environment and urban planning, with the urban planning modes of transport, regional planning, public facilities, and access to markets and services. As we saw in the previous graph, that was actually the closeness to proximity to markets, to services, where we can have a more diversified diversified nutrition. So we can go from pathogenesis to salutogenesis. That's important for the promotion of health that was proposed at the end of the 20th century by Antonovsky, and which deals with how we can generate good health. A good example is one that comes from the Kuopios in Finland. It's in the north. That's where health was the least good as compared to the national average, and the reason why the local authorities decided to act was because they participated in the WHO's European Healthy Cities Network, and they dealt with all the concerns. That was 20 years ago, and they said that before it was typical, it was based on functionalism on the car, centered on the car, with a lack of physical activity for the population, a feeling of isolation for the elderly, a need to have a car even for poor families, because otherwise it's impossible to go to school or to work. And so they tried to change all this by reaching the stage number 3, namely by reshaping the urban planning, by having a sustainable urban planning, by having pedestrian and cycle paths everywhere, by restructuring the pedestrian connections, and by strengthening public transport so that the city center be well served by new bus routes, so they can leave their cars, so that people can leave their cars in the outskirts of the city. And we can see that when we develop health-friendly urban planning, it can have an increase on the stumbling blocks that we can encounter, especially for the elderly. This is a study that was done by the municipality of Genève, and they saw why the elderly would hesitate before walking outside and walk around in their close environment. It was because there were not enough toilets nearby, because of course when you reach that age you need to go to the bathroom often, and the lack of public benches. We needed to, they need to make some breaks and to sit down for some minutes before carrying on. And then there's something about the impact of spatial factors on health and health equity. We have these spatial factors, and then we reach with the outcome on determinants on public health. This is what we see in the last column. So indeed we have different elements that we will see throughout the presentation this afternoon. They appear with the change in terms of urban planning, logistics, and we will focus on the blue circle, physical activity on a daily basis, and access to a diversified and balanced food. Well, when we talk about balanced food, we'll see the next slide. We can refer to the World Food Organization, World Health Organization, because they did a lot of work on physical activity and intervention on debt. And it's true that obesity creates major health risks. Healthy eating is only possible if people have access to healthy, affordable food in the places where they live and work. This is not the case in places where only unhealthy and highly processed foods rich in fat and sugar are available. Healthy urban planning can support local food businesses and urban agriculture at every stage of the food cycle, from production to processing, distribution and composting. The same applies to food waste. Integrated urban planning can significantly support the development of local, fair and healthy food systems. And I will wrap up with this small introduction with the fact that we have already some elements that are important. 10 years ago, a bit less than 10 years ago, we've worked a lot at the annual Congress on health and environment. We worked on this, and the first guide was published. I'm sorry, but we have to wrap up because time is of the essence. Of course, I will wrap up. Don't worry. Sorry about that. So, when the other health-friendly urban planning manuals were published in 2016, 2018, and we reached the last slide, namely, that shows other steps regarding the best integration of health in territorial planification documents, and then a follow-up of reference guides that comes from the Green City project team working on urban planning and territorial planning, and this was done by UNESCO. By the WHO. That's it. I thought I would finish in 12 minutes. That's it. Thank you. Thank you very much, Jean, for this introduction on the subject. We will now give the floor to Kevin Jean, who's a lecturer in epidemiology at the National Conservatoire des Arts et Métiers.
Merci beaucoup pour cette invitation.
Thank you very much for this invitation. This presentation will be about walking and cycling, benefits for human health. It's usually a presentation that I give to non-health specialists. I might sometimes state the obvious, but it's important to remember that people in the general public are not always fully aware of these issues. Now, what about the national debate on active mobility? There has been lots of debate on walking and cycling in the last years in terms of active mobility, and they all relate to the protection environment, cycling to reduce CO2 emissions, and since last year to improve our energy sovereignty. But health is not so much present in those debates at national level yet, as we've already seen that, but here are a few figures. We know that there's a strong link between the environment and health. We know that more than 40% of the adult population in developed countries is inactive, which is an economic and health burden which is quite substantial, with 10% of deaths that can be assigned to physical inactivity and 30% of direct health expenditure linked with non-communicable diseases. So often in France, this is looked at through an individual lens. So it's the same for prevention. But as the ANSES said in a report last year, there are also societal choices, choices in terms of the organization of the public space, the choices in terms of mobility, which all determine inactivity patterns, particularly everything related to mobility. Now, as I've said, I might state the obvious, but first of all, in terms of, as regards the cost-benefit ratio, active transport is extremely favorable. Benefits considerably outweigh risks. We know that there might be risks linked to accidents and air pollution, as there's more hyperventilation in cycling, but benefits really outweigh risks. Besides, we've already heard decision makers saying that they would not have cycle lanes built for just 2 cyclists. Now, there's a wealth of studies, cross-sectional studies, but also experimental studies that show that it's actually infrastructures that generate demand. Now, on a more individual aspect, we know that there are health benefits from active transport, particularly walking and cycling. It's very well documented in meta-analyses, empirical. We know that it's the highest level of standard, or the highest level of evidence in medical studies. So there's a link between cycling and the mortality rate. 100 minutes of cycling per week cuts the mortality risk by 10%, and a bit more than 3 hours walking a week reduces the mortality risk by 11%. In another meta-analysis, there's this relationship for 5 chronic conditions: breast cancer, colon cancer, cardiovascular diseases, dementia, and type 2 diabetes. So there are individual benefits, and we now have at least 10 years of hindsight and epidemiological data with a very high level of confidence on this data. Recently, scientists have tried to document the benefits of cycling in France for 2019, something which hadn't been done at national level. Other countries did, but not France. So why 2019? Well, that year, data on 10-year survey, so data from the 10-year surveys on everyday mobility practices was collected. So this data was published at the end of 2021 and in early 2022. On the basis of this individual data, we have assessed benefits in terms of mortality and morbidity with an analytical framework of the disease burden on the factors of the metrics that I mentioned before, deaths including all causes, and 5 chronic conditions. We've used the EQUIS methodology, the quantitative assessment of health impact, which is very much used by Santé Publique France for for air quality, but which is also regularly used by the WHO. So we first wanted to review the distribution of cycling practice. Unfortunately, I don't have a remote pointer, but you can see on the upper left chart a distribution of cycling per age group. Below you can see the cycling time by age group. So in France we have an average of 9 minutes cycling per week at national level, which is very little. In countries like the Netherlands it's more in the region of 45 minutes. We can see that the relationship with age is not very clear. We can't really see any clear patterns here. However, we can see that there's really a gendered distribution. Men cycle much more than women, whether in terms of frequency or in terms of cycling time. So by using the method that I've just mentioned, the EQUIS method, we can assess the health benefits of cycling in France. That's the right-hand side, the right-hand chart, and it is assessed that in France, approximately 2,000 deaths are avoided in France in the adult population, and 6,000 cases of chronic conditions are also avoided. We're mainly talking about type 2 diabetes, cardiovascular diseases. For the three other conditions, both cancers and dementia, the gap is much lower. It's also important to see that well, unfortunately, its colors are the opposite here, but health benefits are mainly for men, which shows, and it also shows the consequences for the different conditions, type 2 diabetes, etc. So it reflects a more common pattern of cycling amongst men relative to women. So we can see that benefits differ depending on the gender. Excuse me, says the speaker. So economists have developed a number of tools to monetize these health benefits. We have two tools for this. First, what is known as avoided tangible costs, so avoided medical costs. So no reimbursement for society. We've calculated this, and on the basis of the data we have, it has been assessed that 200 million euros of costs, of medical costs, have been avoided thanks to cycling. The problem of avoided medical costs is that it doesn't take into account at all mortality. So 2,000 avoided deaths is quite substantial, and avoided medical costs do not take into account avoided deaths. The method to take this on board is to calculate intangible medical costs. It's a concept developed by economists on the inclination to pay. So the daily, the number of years in good health, as mentioned by Jean. So for each year of life, you can associate different factors. So by taking this into account, we can say that about 5 billion euros of costs are avoided every year. It's quite interesting because you can compare this with the number of miles covered every year, cycled every year in France, and if you do the maths, you have approximately €1 of intangible cost avoided for each kilometer cycled. This is a unit cost which is very interesting for supply chain and haulage companies, because above a certain threshold in terms of euros, when investments are considered for public transport, you need to carry out a socio-economic assessment. And so far, the metrics used for cycles were, for example, the dwell time in transport or the quality of air, but not this aspect. Now, if you factor in physical activity, it changes. €1 of avoided intangible cost, which is 10 times as high as the previous value that did not factor in the benefits of cycling, of physical activity. So I've talked about the data observed for 2019 in France, but we can also look at this through the carbon neutrality lens. a number of bodies, of agencies produce carbon neutrality scenarios, roadmaps that describe how to achieve carbon neutrality in each sector in France in a credible and consistent fashion. In the first study, we used the scenario produced by the Negawatt NGO, which was really a pioneer in forward studies for carbon neutrality. They have been producing this kind of scenario for about 20 years. The Negawatt scenario is one of carbon neutrality by 2050, which is very much based on energy conservation, but also energy efficiency. In this scenario, Negawatt describes expected evolutions to reach carbon neutrality in active transport. It's the two diagrams on the right-hand side. First, the weekly mileage on the left-hand side, and so exposure time, an exposure time for walking and cycling on the right-hand side. In this scenario, Negawatt assumes that cycling volumes will go up 6 or 7 times between now and 2050. So that means that the weekly cycling time would be much larger, but it still remains below the level of countries like the Netherlands. When you apply the quantitative health impact analysis, the EKIS method, on these projections, so the walking goes up, but not so much. So you can actually, by using this method, you can work out the health benefits of these carbon neutrality actions. And you can calculate the number of deaths avoided every year. In the Negawatt, it's 2,000 deaths avoided every year. With the same monetization process, you get 35 billion euros of intangible medical costs avoided each year. And in the general population, this leads to a gain in terms of life expectancy of about 3 months for the general population, which is quite an ambitious objective in terms of public health. So we're talking about a transport objective for climate purposes. So you can see it's the idea is that to factor in health in all public policies. Now, this was one scenario, one carbon neutrality scenario, the Negawatt, which is really much focused on conservation. Now, the ADEME, the Agency for the Environmental Transition, recently developed 4 scenarios, 4 very different and contrasted ways of achieving zero net. You have 4 scenarios. The 2 scenarios on the left that are bluish are very much focused on conservation. The 2 scenarios on the right-hand side are much more technology-oriented. And the reduction of carbon emissions from transport is much more based on electric vehicles. These 4 scenarios are more or less equivalent in terms of CO2 footprint, in terms of climate footprint. But when you show these first results, you can see that it's not the same for health benefits. And you can see the number of deaths avoided by 2035 and 2050. And you can see that the expected number of deaths for avoided deaths is much higher for scenarios that focus much more on conservation and efficiency, whereas on more technology-focused scenarios, where electric cars are much more at the center, you can see that in terms of health, the overall result is not so favorable. So we can see that at first sight, you can see that scenarios that at first sight are equivalent in terms of CO2 footprint. When you factor in health, the results are quite different. And it's not something that's done very much in the public debate in France. It shows that public health can be a very interesting compass to choose between different societal choices. I'm done. So I've tried to show that the debate on active mobility through the climate lens and energy lens could really benefits from the public health dimension. And clearly, some partnerships should be entered into in terms of research, in terms of climate and health research. Thank you very much for your attention.
Timing parfait.
You have perfectly complied with the allotted floor time. Are there any questions from the floor? We have a few minutes left.
Merci.
Hello, thank you. Thank you for your presentation. I'm currently trying to promote cycling for its health benefits in the local government where I currently work. And there's a lot of resistance. We have cycle lanes, not paths. There are signs that say that cyclists have the right of way, but people are afraid of cycling with their kids in the public space because of some disrespectful behavior of local motorists and because of rather angry driving style. How can you fix this? Policies were introduced for cycling infrastructures, but they didn't really follow it through, because we also need to work on acceptance amongst motorists. Yes, well, one avenue is exactly what you said. It's the difference between cycle lanes and secure cycle paths where people will not behave the same, where they won't have the same feeling of security. It's different if you are fully separated, if you can drive on a standalone path. You know, it's different. I don't know if you've already seen this picture of a balcony where you don't have a handrail, but just a white line which is drawn on the ground. I think it's quite clear. You know, since a number of secure cycle lanes have been delivered in some municipalities, there's been a boom in cycling. Thank you very much. You were saying that in the negawatt scenario, walking didn't really go up. Do you know why there aren't more policies that target walking? I think that 75% of commutes or trips shorter than 3 kilometers are done by car, whereas you could actually walk them. But as far as walking is concerned, I think the main two reasons is that it's because public authorities believe that there's already quite a lot of walking and there's less room for development, whereas cycling is very limited in France. You have different scenarios. In terms of distance, climate and heat, this is something that can be rolled out very quickly, and it will have a much bigger substitution effect than for walking. I have a question. I'm Barbara Eudes. I work for the INSEM Research Institute in Villejuif. My question was about electric technology. Are we going to get any data anytime soon about electric bikes to factor this in, about health benefits and also environmental ones? Right, some information about health benefits. There's a number of studies which go back some time, so it would be good to update them. But on an electric bike, you basically deliver, it's basically 75 to 90% of the physical exercise on a standard bike. It sounds a bit high. Now, clearly, on an electric bike, physical activity is less, but people travel greater distances, so it actually balances out. As regards environmental aspects, this is really very well calculated in life cycle analysis. For example, a small battery for an SUV could power 60 cycles, 60 bikes. It is also considered that electric, in order to be carbon neutral, you need to travel 600 kilometers with your e-bikes to again, it's electric and it's quite light in terms of resources. And I don't have any interest to report here. Thank you very much. Let's now hand over to Valérie Parent, who is a design engineer at the Regional Health Agency in the Auvergne-Rhône-Alpes region.
Hello everyone, thank you. I will talk to you today about experiments that were carried out in Auvergne within a specific plan, and I will talk about the feedback that we got so that we can understand where we stand now, because these are the reflections that will allow us to condition the action plan that we are currently drawing up. But before that, before starting, I will give you a historical background to tell you that the first initiatives of this type started in the region in 2012, and at the time they were health environmental impact study in large urban centers, Lyon, Grenoble, Saint-Étienne. And it was, at the time, it was the ORS, namely the Regional Health Observatory, that took place, that did these ESs, these strategic environmental assessments. Well, it has evolved since then. What it shows, this graph, is that starting from the orange circle here, we can see the impetus that was given by DREAL and ARS, namely the Regional Directorate for the Environment, Planning and Housing, and the Regional Health Agency with the elected representatives. That's the target that needed to be reached. And this is why we try to find organisms, bodies, local authorities to work between the local authorities, the elected representatives, to help them. In 2017, these are the 4 urban planning agencies that were ready to make experiments within their networks with their members. And they are the ones who did it, who managed to have capacity building plans with the technical support of the Regional Health Observatory. So we have the map of the region, and we see the 8 territories where the experiments were carried out. In green, we have the new initiatives. And as you can see, we looked into vast territories at the scale of communities of communes with very different plans, with different intercommunal urban planning plans, with different programs, and we worked with more operational programs on a country which is called a small town of tomorrow, Petite Ville de Demain, and we work with that so that the development of health urban planning programs should not be reserved to large towns, but also small towns should have this. And we should think about interconnection with the plains, with the mountains, and rural areas. How do local players perceive and see healthcare? That's a synthesis of what we have collected from the experiments carried out, and we can see that this is the input that needs to be promoted. What comes back again and again we need to have an approach that rallies everyone, a unifying, a universal theme, and the approach should have a transversal approach to territories with a new vision, a new outlook, and putting the human being at the forefront of urban planning documents and programs helps us giving more meaning to the actions carried out by the public authorities. The approach requires a break with the silo logic of internal organizations and territorial approaches. This is something that can be interesting for local authorities, and it's difficult for everyone to work on their own. And that can allow us also to better understand some issues that reinforces or legitimizes the relevance of some planning choices and public policy choices that may be controversial, so we can actually lead to consensus. Now, I will try to highlight the drivers in terms of factors of success around these experiments. So what was highlighted was the educational and collaborative dimension of the approach that can be made sustainable through our culturalizing stakeholders program around a shared environmental health diagnosis. There's also the importance of taking part in the projects at the beginning of the project and the plan, and to forge links with the local players, local authorities present on the territory. The importance of having strong political support with ownership of health environment issues. This is a big challenge, and so maybe we should raise awareness around territorial health environment diagnostics at larger scales, so that territories can find landmarks, can find the social inequalities in health compared with other regions. We should also integrate the HUP approach into existing schemes. This is important to reach out to networks and schemes and to understand that it's something that is not in addition, but when we review a document, well, this will give the opportunity to integrate that type of approach, and we'll also start to look into what is already being done in terms of HUP to have more people on board. There are drivers in terms of the evolution of practices. We develop a positive approach. We talk about the co-benefits between the environment and health. And then, for design studies, we have to train also the urban planning officers so that we can clarify the links between strategic environmental assessment and HUP. These are the documents on which the regional healthcare agency can work, and the link has not been done yet. The bridge between the two has not been built yet. As for other drivers, this is more in relationship with the territorial constraints. Maybe I'll go through that more swiftly, but when we have to help adapt support to the local characteristics of the territories, because we don't always have the same stakeholders, the inequities at stake are not always the same. When we have to deal with the jurisdiction of elected representatives, and we need also to have motivated and grounded terms of office, and we need to have an interest in having dedicated and trained officers. Also, the local authorities focused on these plans, that can be also an opportunity to highlight the fact that this can bring the stakeholders around the table and to try to upgrade our debate with issues that will unify more and better. And then there's better training is needed, better knowledge among local authority elected representatives and technicians. We need to think about some support for tomorrow and over a longer term. Another pillar, we need to strengthen community involvement by reaching out to the services that are in charge of public consultation within local authorities, by involving residents' associations. We should reach out to health professionals in planning processes to make sure that health-friendly urban planning is recognized as an important tool, as public health tool. That requires a lot of work to integrate it fully within the regional healthcare agency, especially with the local health contracts. We need overviews and probative evidence and figures that can be useful for advocacy purposes. We need training and to better understand data interpretation. So, amongst all this input, the overview of which I gave you, we need to have educational tools, teaching tools. These are reminded here on this slide. We have a technical report that is quite comprehensive. We have 3 testimonial videos. And we also have fact sheets, educational fact sheets that bring about methods for project leaders, especially the fact sheet that is in green, which is a document that aims at convincing and telling everyone that we need to act for local representatives. It serves as an advocacy tool. And then we have technical fact sheets, methodological sheets to highlight the mistakes that should not be made, and then for any kind of local plans, for urban plans, everything that we need, and feedback sheets as well, because sometimes we need to see more concretely what it means, what we could do, the kind of projects that we could implement. Last slide, to give you some background, the objectives of the program to develop a health-friendly urban planning. So we have to work with the stakeholders. We have 2 pillars, one that is within the PRSE4, and we will promote health-friendly urban planning with the local authorities, and we'll have the best practices that will be disseminated. We are rolling out awareness-raising campaigns amongst the territories. We're also building, drawing up suitable training sessions, and we organize also collaboration between the local authorities and having a sustainable vision to see what kind of organization we have to set up to make it sustainable. Then alongside this, we have a second pillar, which is more turned towards practices within the regional healthcare agency, because this needs to be done also with the other institutions, especially the DREAL and the DDT, to try to work together to find out the key moments, the crunch moments where we need to act, to see what kind of investment is required when plans and programs are being established, to work on internal processes, but also to identify partners in each region to take action, because the specific features of the local authority at stake need to be factored in. Thank you very much.
Merci beaucoup.
Thank you. Do we have any questions?
Oui, là-bas.
Yes.
Bonjour. Bonjour, Mélanie Ballot.
Hello, Mélanie Ballot. I would like to know if you have concrete examples to show us, 1 or 2, from actions that were set up within this plan called PRSET in terms of HUP, namely health-friendly urban planning. Well, we have some feedback sheets, but the aim was to reach out to establish diagnostics. It always starts with awareness raising with all the services within the local authorities to make sure that the issue is acquainted with, and to have discussions, to share the issues, and to find venues for thoughts and action, and to involve local authorities. This is the starting point. The work is done over several years. The aim, of course, we need to start well, to end well.
Et du coup, est-ce que vous... Enfin, il y a une question là-bas? Non, c'est pas une question. Est-ce que vous êtes amené à travailler peut-être un peu plus particulièrement avec certaines villes qui sont peut-être...
Are you meant to work with some cities that work as drivers to go to other territories that are less advanced, that received, that were less made aware of the importance of that issue? That's part and parcel of your advocacy program, maybe. Well, when we arrive in a territory, we have to know at which scale we're working. If we are in a neighborhood or a town urban planning program, this will be more concrete for elected representatives and stakeholders. But we can also reach larger scales, like communities of communes, namely several cities brought together. It's important to find the right loop between the different cities, and it's very difficult when we draw a planning document, because we need to think about all the consequences to see how the domino effect that it can bring about. And this is something, a project that can be submitted to neighboring cities, and hearsay works as well. So you have a question online. Can you tell us the most important argument? We're talking about the advocacy guide you mentioned earlier. What is the one full argument that you could put forward in favor of your program? Well, they all are already implementing policies that relate to health without knowing it, unbeknownst to them. That is the first message to convey. Okay.
Merci encore.
Thank you.
On va passer à l'intervention
suivante. And we
suivante.
will now go to the next speaker. I'll give the floor to Diane Bayeux, who's a dietitian, and he's working at the Réunion. She's a director of health promotion at the Réunion, right? The Reunion Island. Thank you. Hello, everyone. Thank you to Santé Publique France for giving me the opportunity to share our research and all the plans and programs that we are implementing in our neighborhood. So, first of all, there's no conflict of interest. So this project on the territory of Camellia, and I'll go back to the specific features of the territory. It's a matter of two stakeholders. First, we are known as MUTA by the Reunion's residents. Beyond being a supplementary insurance fund, we are a social and solidarity economic group, the purpose of which is strongly, it has a strong social focus, and this is turned towards all the Réunion residents to give full access to healthcare. For promotion activities, it relies upon a network of association with skill sponsorship networks. And then we have DNA 107.4, which regroups all the type 2 diabetes patients. And that's actually a very innovative program within for diabetes in the Réunion. The choice that was made was to invest in a proximity program within the Camellia neighborhood. So Camélia is in the north of the island, in one of the most ancient neighborhoods of Saint-Denis. It is a neighborhood which was the first to have social dwellings, 7,800 inhabitants, with underprivileged social and economic factors in terms of precariousness. There was an urban overhaul that took place in 2019 that needed 10 years, and the association networks is quite dense, but very few are willing to work on the topic of health or physical activity. And last point, it's a sensitive neighborhood, as we say, and has been the subject of a lot of negotiations, well, a lot of political controversies, and there's a huge public distrust of projects that are submitted to them and that do not have a long-term perspective. This Camélia Santé project was born end of 2017 and is in line with the continuum of the Consensus Diabetes Conference that took place in 2016 to establish a nutrition obesity diabetes plan. A call for project was then launched by the Regional Healthcare Agency of Réunion to receive projects that would be enshrined in the territory, tailor-made for the territory at a lower scale, to make sure that the range of actions could be of help and could be implemented. This experiment lasted 2 years. The aim was to rely upon 3 main points: promotion of physical activities, promotion of a balanced diet, and supporting people at risk of diabetes or with diabetes. So this first stage required to work with partnerships at the territory level, but also to have community health programs and to involve the population in all the actions, all the activities that were designed and implemented. At the end of these 2 years of experiment, 600 activities were rolled out among the population. There were activities, physical activities that were developed. The impact was quite positive after 2 years. First of all, in the neighborhood itself, the neighborhood became more vibrant. There were more sports facilities. There was also awareness that was raised amongst the residents, but also the associations that were present on the territory. And among the professionals, healthcare professionals, they started to work together on a project, prescription sport project, and something that can be an anecdote, but you know, we have a lot of carries there. So we've had some news from a lot of restaurants that adapted their menus and that they would offer more vegetables, less salty dishes, for instance. And then there were programs linked to health that were developed. We could see different positive impacts on stress management, on stress, on social ties, and the capacities to have more social relationships, more interpersonal ties. We could then identify a certain number of activities around physical activities, such as Zumba, outdoor Zumba sessions, or to have urban pathways. The population was really supporting this and was satisfied with this, and that managed us to have a basis of trust with local residents and to have some consistency with the partners that were already in existence. But during these 2 years, we had new infrastructures installed in the district. with a social center, a cultural center, but these facilities were not well seen eye to eye by the population. And we could see that during these 2 years, the social link in this urban neighborhood was deteriorated with a lack of intergenerational link. The market, for instance, that would prevent the elderly to buy the fruit and vegetable, the social link was really deteriorating and weakening. And in March 2020, we had the lockdown. So, even though that was something that we had thought about already during the 2 years of experiment, the lockdown related to COVID had made us think about how we should approach health through this project. And the conclusion that we drew was that health is not only food, diet, and activity, especially in a neighborhood like this. So what we wanted was to start thinking about all the health determinants on which we could act. So Camellia Santé turned into Camellia Village project, included in a more exhaustive, in a more comprehensive project. And the idea is to help the residents in transforming their neighborhood towards a village that would be health-friendly, as opposed to the word neighborhood that could have a negative connotation. With the idea of village, we have a positive connotation, maybe be in terms of facilities, but also in terms of social link. And for this project, we use a social population, popular health education, and the objective of this comprehensive approach is to have well-being and fulfillment of all the residents, of all the people living there. So Camellia Village was a collective ideal to be designed by all the inhabitants. The project has a logo, has a slogan, has a charter, to which all the partners, residents, but also institutions committed. So this Camellia Village project aims at acting on 8 pillars simultaneously. Yes. Very similar to what we saw this morning. We knew that it was complex to work simultaneously on different determinants. It's not easy, but it can be very promising. So we worked on youth, on education, on seniors, on the elderly, to help living together, specific actions surrounding families and health. We also developed a cultural component, an environmental component, one on economy, one on reinsertion, on re-inclusion and quality of life. And you can see all the associations whose formation we instigated for this project. When we talk about sponsorship of skills, we actually help these associations to function on a daily basis, to operate on a daily basis, so that they can implement the different projects that are theirs, that they instigated. So Camella's Village is more than 60 actions and projects affecting nearly 450 people every week. And what is important is that each person finds their own place and can contribute to the village. I will just focus on 4 actions. Regarding governance, this Camellia Village project is steered by a committee of ambassadors, 30 inhabitants and association representatives. They meet every month. They almost have a daily involvement in all the activities, and they also work in unifying partnerships. There are volunteers that want to improve their practices, mainly in culture, environment, in health, And without them, the project would not be where it is right now. On education, we have what we call la Cité des Écoliers. That's about to end its third season, the Scholars City. And it affects all the pupils of a school. Every Tuesday afternoon, they are sent out to different centers in the village. And during school time, they have workshops, activities that are provided by teachers, by shop owners, by educators, and so they can see education in a different way, and this has a favorable impact on their behavior, their ambitions, and their outlook on adults as an age group at large. Then we also have music. This is very important. We wanted to identify all the artists that were living in the village and give them the opportunity to gather every week in a public square to have a musical jam session. And today there were 30 playing also with school pupils to have some musical jams all together, and that has become an important moment for the population. It's a high-quality time also for people suffering from addictions, for the population, because they all are together at once during that time. Then another activity which is important for urban planning is shared gardens. During the lockdown, we had seen some initiatives from inhabitants that could set up shared gardens down their buildings, and we actually wanted to pursue with these initiatives with some gardens. We have 18 gardens that were set up, and they modified the layout of the village. We have now food production coming from these gardens. We have productions that come. We have honey as well, which is quite well known, camellia. And these shared gardens are important because people meet there, work together, they have access to a better and more sound diet, more healthier diet. We started in 2017. We want this project to continue up to at least 2030. And the projects we have for the years to come are, first and foremost, to focus on global and integrative healthcare by building pathways with health practitioners, with stakeholders coming from the health sector. But we need to build pathways by what we call social prescribing, so that we can implement these assistance programs and to pursue with these ecosystems that we created with economic benefits, so we can reach self-sufficiency. We mentioned, for instance, that we should implement hydro systems within the village. So I finished. Thank you.
Merci beaucoup pour
Thank you for this this wonderful project. Do we have any questions? Thank you. More than a question, it's rather a comment, because I thought your presentation was smashing. If I understood well, you came from a strong force of will to give impetus to community health projects, and that has known some ebbs and flows at the beginning, because the population did not adhere to the project, but then you had popular adhesion in the end, because we have talked about it. Well, we went around that subject without really tackling the subject. We need to have adhesion from the peoples. It's a good thing that the healthcare professionals give an impetus, but then we need them to accept it, to own their project, and to be fully involved in the end in the project. Thank you. Yes, as a top-up, when we talk about professionals, when we talk about the mutualité and the association ADN, it's first and foremost volunteers, grassroots volunteers that created these structures. So what we do is implement their political and social projects, and the conversion towards this project in connection with the population that was made possible because they were volunteers at the starting point. Their concerns was to satisfy in a straightforward manner the population's needs as a whole. I have a small request from the text. Someone would like to take the floor, but his mic is actually muted. Can you hear me? Can you hear me? Yep. Thank you, Mrs. Bayeux. Your presentation was very interesting, and the shift from Camille Santé to Camille Village is very interesting. That joins our analysis that we made with Santé Publique about Guyana. By analyzing this, we saw that the situation in diagnosis was very different from the situation in mainland France. But there were a lot of similarities with La Réunion, especially the issue of diabetes. This is an important issue in Guyana. I don't know if the same is also valid for La Réunion. We discovered that yogurts that are sold have a blood content that is higher than in mainland France. So diet is important, but also social link is important. We saw how important it was. This is my question. You've talked about pupils and the school project, but you focused on one school. Could you unify all the neighborhood schools? Because what we saw in Guyana, that 1/3 only of the schools have a canteen, and that's very important to have to make sure that pupils would have at least one meal a day, because some of them did not have food security. And there were also other structures around the school that would not give a balanced diet. And so the most important thing was to strengthen the presence of school canteens in the different neighborhoods. Is that a situation that you also have in your neighborhood? No. The situation is much better in Réunion. All the public schools have a canteen, so all the pupils that need to have a meal at lunch can have it. However, there's another problem, namely snacks, fast food restaurants and fast food trucks around the school that do not provide a balanced diet. This is a real fight that we have to put with the local authorities to try to regulate the settlement of these fast food restaurants. As for the school canteen, for the schools, I did mention one project with one school, but there was a second school that was not as vibrant as the first one, but it has found some relay from a certain number of stakeholders to work on the environmental and sports activities, so not in the same dimensions, but we are managing to have an impact on most of the pillars, and we try to work as early as possible with the pupils to make sure that it is sustainable, to contribute to their education, to change behaviors in a sustainable way for their life ahead of them.
Eh bien maintenant, s'il n'y a pas d'autres questions, on va faire...
Right, if you do not have any questions, we're going to have a short break, about 10 minutes. Let's try not to be behind schedule. Thank you.
Eh bien, on reprend cette session.
Right, it's time to resume the session. We are joined here by our next speakers, Brice Van Aren and Mirjam Weber.
Et on va recommencer avec
and we are going to resume with Yannick Nadessan, who is the chair of the French Healthy Cities Network, who is the deputy councillor for aging for the city of Rennes. Are you connected, sir? Yes, I am.
Donc on est au regret de ne pas pouvoir vous voir, mais on vous entend bien.
Well, it's a pity we can't have you with us. Oh, yeah, we can actually see you. Sorry. You're right behind my back. Sorry. Perfect.
Laisse la parole, c'est parti.
Right, over to you. Thank you very much. You have 15 minutes.
D'accord, merci. Donc, je suis dans votre
Thank you very much. Well, I'm behind you, but I am here indeed.
On a sur
Greetings, everybody.
Une forme de combat qui est encore à mener.
We still have a fight to wage in our health approach to give recognition to cities in their actions.
Les villes en matière de santé.
And there are still questions about cities in terms of health. Cities can still do something. In our country, people tend to think that health is first and foremost about care, that it is the exclusive preserve of the private sector, the state, and social security. But when you talk about COVID, you can see that as far as the distribution of masks is concerned, as far as the screening centres, vaccination centres are concerned, nothing would have been done with the same speed and efficiency without cities. And everybody spontaneously agrees to that. People say, oh yes, that's right. And actually, the role played by cities go even beyond that. And the RFVS, the Network of French Healthy Cities, is a group of these cities and these intermunicipal groupings that want to have a global approach, a holistic approach of health. Next slide, thank you. So here's a slide that presents this network, the RFVS network of the WHO, which brings together 104 cities, towns and intermunicipal groupings with 13 million inhabitants. Now, we're not trying to cover the entire country. We're not in a race for members. We just champion a specific approach to health, which has one ambition, a holistic approach, which is the WHO's approach on the physical but also mental well-being. We want to create general well-being. It's not a narrow-minded approach of health, which just focuses on the absence of illness. And actually, coming back to COVID, we can see that this approach has gained ground, particularly in mental health, and with this assertion that everybody has a mental health. And with COVID, we have all seen at first hand that we had a mental health that could fluctuate depending on the stages of our lives, that there was a kind of mental weather in our minds. And this was a very strong priority for our network and for our cities during COVID. In our values, we also have the cross-sectoral aspect, the idea that health is an issue that covers all policies, equity as well, with the approach of proportionate universalism, we have an approach that seeks to address everybody, but which takes into account existing inequalities, which means that we have to give more to those who are underprivileged. So that's why we need to include the regional fight against inequalities in health. And thanks to our skills, we can take action in the long term. We can also take action in the short term, but we do have actions in the long term as well. And it's quite obvious for local authorities that have powers for early childhood and young people. So these are the values of our network. And we operate across a variety of regions, as you can see on this map. We have a number of experiences from different cities that depend on their history. We have rural towns, we have cities with a lot of students, university studies, we have aging ones, aging cities, cities with an industrial legacy. Also, we have cities in very different climate environments, by the sea, etc., etc. I could even say that some cities are affected by droughts, others are not, but actually today all cities are affected by water stress. But there's a diversity here in our regions and experiences, but it's a source of it's a great source of experience, a rich source of experience. So we have in our cities pairs, people that work in pairs, elected officials and technicians. They work together for analytical work, scientific work in connection with our secretariat, which supports people. It's a multidisciplinary team of 5 people. And the idea of this network is that people bring their own experience and commit to the network. And we are very satisfied, very pleased with the vitality of the network. Even though, as I was saying, we're not really actively looking for new members. And actually, well, this map is a bit old because new regions have joined us. For example, the intermunicipal grouping of the Greater Angoulême or the city of Roanne. Next slide, please. So, as I was saying, cities can act using a number of levers in terms of health. 80% of a person's health is determined by their environment, their living environment. But authorities often tend to neglect everything related to the socio-economic context, which actually mainly determines these 80%. Now, one could argue that we don't have a lot of influence over the professional or over the workplace, but there can be a dialogue between local authorities and employers. And local authorities are themselves major employers. And so we can have an influence over the living environment. Last week we held our major annual symposium in Nice, in the south of France. The theme this year was health and climate change. And again, we realized that cities played a very important part, that they could really have or make a change in the health of their constituents. Why? Towns and cities are places of population concentration, and also there's a lot of evolution going on there. But cities and towns are also players that have major resources. They can change or they can act on greenhouse gas emissions. So there can be long-term and also short-term effects that are considerable, and they can also make a real change with pollution on health. For example, as regards greenhouse gases and air pollution, they can work on mobility. So thanks to intermunicipal groupings, we have control over mobility policies, carriageways, streets, roads. So we can act on mobility, we can create or promote low-carbon mobility. Besides, as far as housing and buildings are concerned, cities, towns have powers in this area. And also now, with the so-called regional dietary plans, which are more in line with our traditional powers, we are becoming major players in everything related to agriculture and food. So I've said that we have powers in housing and agriculture and food. So you can see that these are major instruments to act on climate change. I'm not even talking about the greening of cities, the preservation of farmland and natural areas, also the setting up of cool islands, coolness islands in cities. And that's and authorities turn to us for the creation of low emissions zones, LEZs, also to fight greenhouse gases, to fight air pollution, also for local integrated management. Many of our inhabitants live on the coastline by the sea. They have to deal with the rise in sea levels. Also, we have other priorities such as the reduction of land take. So we really have a way of acting on health. I mentioned earlier on equity. This is also something that we can see in social justice. And for example, as regards low emission zones or zero net land take, well, the central government tells us that we need to ban polluting vehicles in the metropolitan areas, that we have to stop land take on farmlands and natural areas. And on this, we agree, but we find that we get very little support, so do our populations, particularly those with the lowest income. For example, if you want people to go electric, to buy electric vehicles, or if we want to have a better control in the management of land resources and be better protected against land speculation. And the problem is that property prices are already very high in France, and all this speculation has a bearing on housing conditions, and also a lot of consequences on health. So I think we can move on to the next slide, if you agree to it. You have 2 minutes left. Right, as regards the internal organization of the RFVS network, so we have a lot of theme-based or dedicated working parties. You have a few examples here in this list. So these can be long-term task forces or project groups. Members are cities that volunteer for these task forces. It's all based on consensus. We have plans, we create plans of action and different projects. I've got some concrete examples on the following slide. So one of our projects at the moment, one of our task forces, is the use of local observation in health to reduce social health inequalities, ISS, and improve local action. We realize that towns and cities and intermunicipal groupings are a great source of resources. For example, local urban planning agencies that have statisticians and people who collect data. But also, we need to have access to data which is owned by other institutions, and we have to fight very hard for this. Of course, we want to be able to have an evidence-based approach of things. We need to be able to warn populations and to work with all professionals on the basis of this data. So to have an evidence base for all our awareness and prevention work in health. So there will be a next stage in this work in October. Next slide. One of our main pieces of work this year was this healthy diet and physical activity. It's a more than 800-page book, which includes a lot of personal stories and experiences that are very interesting. We can look at the next slides. So there are several levers for action. Our cities and metropolitan areas also have farmland. The Rennes Metropolitan Authority, also in Brittany, 50% of farmland. And these are areas that we need to reclaim to create, for example, urban gardens. Also, we need to promote physical exercise. We need to promote active mobility with cycling, walking. We really need to work at local level. We also need to green up schoolyards. So all this is part of our powers with the protection of air quality and water quality. Next slide. And also there's everything we do now in terms of catering or food. So we're now required to work on the supply of foods to our schools, a sustainable sourcing. But we also have to work on agricultural production, so we need to cover the entire agricultural production chain. We have to encourage farmers to embrace virtuous practices. Also, we need to improve water and air quality. Also, we need to work on food. It can be through catering or food aid. We can have, for example, local organic food baskets that can be distributed to vulnerable populations. So we can see that cities can do a lot. I'm sorry, I know I have to finish it here. But there's all our work also in relation to physical exercise, either with the municipal staff or with subcontractors and health professionals, of course. And I think that's about it. There's one last slide where you have our contact details. Thank you very much indeed. Are there any questions? Maybe one question? Yes, go on. Hi, thank you for this presentation. Just a question about the levers that cities and towns have. What about public tendering? Do you think that cities can use this lever? You mentioned business, health in the workplace. Is that something that cities could work on with criteria? with specifications? Or does regulation prevent cities from doing this? Will it be possible in public tendering? Well, there are obstacles, but also there are things that cities can do. For example, as regards internal air quality plans, etc. Some of our cities include criteria in public tendering to regulate the type of materials that can be used. So, for example, for the energy retrofitting or renovation of buildings or for the construction of new ones, but also as regards cleaning products in buildings that receive infants and young children. But also we have public tenders for catering, where again a number of local authorities work on this. So, for example, local organic sourcing with quality produce for catering. But public tenders are also regulated, or there are restrictions depending on the type of tender. But we can do something. We have dietitians and doctors who try to determine what should be in your children's plate. People often think about children, but and they're right. But there's also the fight against denutrition for the elderly in care homes. And there are also other criteria related to enjoyment and to the texture of what's put in your plates, but it's completely different from environmental criteria, for example. So we work with professionals, food or dietary professionals and health professionals. Well, I just would like to pick up on a question that we got earlier on, and that could be asked. Sometimes it's difficult to install this concept of RFVS of HUP in rural towns, because they don't always feel concerned by this. So do you know any ways this concept, HUP, healthy urban planning, can be better promoted in rural areas? Well, that's my personal take, but I think that we are on the receiving end of planning, of our planning policies in the last decades, which have not benefited health at all, because planning was mainly focused on cities and metropolitan areas. So town and country planning did not focus on the right distribution of services across the country with a network of small towns, for example, as regards the distribution of public services. Or when you look at the distribution of residential areas, for example, residential estates that are far from services. So objectively, the living conditions of many people in the population mean that people have to use their cars. It's not really favorable it does not really encourage active mobility. And people tend to forget this. And I think that HUP, healthy urban policy, for rural towns is actually a way for them to take back control over planning in a virtuous way through the health lens. It's one way of developing regions again. But right, thank you very much. I suggest we now move on to Brice Van Ayen, who's the development engineer in the Strasbourg's in Strasbourg. So it's the Adius.
C'est bon, vous m'entendez?
Can you hear me all right?
Très bien. Voilà, j'ai un titre un peu long.
My title was a bit long and complex, so sorry about that. So HUP, it's about HUP between engineering and opportunity. So we will see how we can have health-friendly urban planning to gather conditions that would be conducive to walkability and cyclability, as said earlier. Infrastructures need to create the offer, and this is why we have to work on this. And working on proximity facilities is a concept also to try to make sure that the public space is satisfied, but also to allow accessibility on a daily basis. So a small reminder on the background. We are in a global warming backdrop. You certainly saw that. Strasbourg has been declared in a state of climate emergency since July 2020 by the municipality of Strasbourg. We have a worrying level of air pollution with a proven negative impact on health. 500 cases of early deaths because of air pollution. This is also linked to Strasbourg because we have a highway that goes through, that cuts into the city, and we have a structuring road, which is the Avenue du Rhin, which links to Germany. We have an erosion of biodiversity that is strong in Alsace, with a reduction of species, of amphibians, of mammals and birds. So with this proximity plan, we have new challenges but new ambitions. The aim is to decarbonize mobility, to improve air quality, to calm the city and to rebuild social links. We have the carbon agreements but also the Paris agreements as a backdrop. We aim also at planting and demineralizing to reduce the heat island effect, to provide shade via plant canopy, to act as a natural air conditioner, and to enhance biodiversity and ecological continuity. So what you can see is different cycle paths, and we want to go from 33 to 37% by 2030. And for the bike, we want to go from 8 to 16%. So we already stand at quite satisfactory levels, but we want to go further. And to do that, we have to change the layout of the public spaces. The idea is to have a systemic approach to mobility, to have a city model that would be calmer. This is the pyramid that you can see here. The aim is to reverse it, to give more space to pedestrians and bikes, so that there are more cyclable infrastructures that would be safe, to have more active modes of transport and to move away from what we have. It's a three-stage process, so we would go from a slow pedestrian and cycle route to serve all the proximity service as a wide in a wide meaning of the word: restaurants, doctors, parks, bakeries, grocery shops, and to have more greening. So we combine the three aspects to have a green a local green grid. This is in line with slow network. We're not having highways or big avenues and roads. We're having a small mesh networks that go from 20 to 30 kilometers an hour in slow, so that would be a slow-moving network. In terms of characteristics of this grid, the aim is to have continuity and legibility of the path and the route. You see the small scheme. We have all followed a cycling path that corresponds to the node, and that is very unpleasant. Same thing for schools. We need to access to schools. We need to have access to central services such as shops, local amenities, bars, bakeries, grocery shops, and the presence of pre-existing avenue trees. These are the characteristics that can help us, that can give us a method to draw this local green grid as we aim it. Another characteristic is the creation of a fine grid of vegetation. We have, on the one hand, the aspect of biodiversity, because this is in line in a green and blue grid that exists already in the mainland France. We want to have a fine meshing, as you can see in the grid illustration, and we can have also green areas along the side, and this is as prescribed by the WHO. So we want to have green areas in the vicinity. So that's the test area. So on the top-hand side, on the right-hand side, you can see a neighborhood. This neighborhood has Cronenbourg, which is a neighborhood of Strasbourg. We foresee another case, Schiltigheim, and Niederhausbergen and Mittelhausbergen, which are middle-sized neighborhoods. So we have a grid of 300 meters by 200 meters. We see then afterwards the green. We have the proximity green areas in this fabric that lacked green areas with a huge diversity of urban networks. We have structuring areas here on the sides, and we have one street out of three that will have green areas with soft mobility paths that will help to serve the local amenities and shops, and that is in line with the WHO recommendations. If we do this grid of 300 meters by 300 meters, we see that the whole territory has at least one portion of green area as recommended by WHO. So on this map, we also see that all the close shops are in proximity of this green grid. Everything that we see displayed is bakeries, small supermarkets, green areas, and in this way we can have all the local amenities nearby. So we'll have a study of three cases in three different studies: a neighborhood street, a school street, and a residential street. The first one is the connection, the Rue Saint-Florent in Strasbourg. That's a connection between neighborhood centers, including parks and gardens. It is a heritage street with a view, an existing tree line as well, which gives shade which provides shade to cars which are parked there. We have a space dominated by cars, 78% of public space, 122 parking spaces, and a very low permeability soil. The idea is to reshuffle this place, to have a garden, to go quite far away, to plant a central median and facade fossile, to have meeting zones on the roadway, so that means that we do not exclude cars, but they do not have priority over pedestrians and cycles and bikes. And all the car parking that we had will be used for pedestrians to provide shade. It will be used for the benefit of walkability, of walking. We'll have benches as well, because what we have integrated, as seen earlier in a previous presentation, that for the elderly, one of the drivers to walk around is to have benches scattered all over the street to have breaks. And lack of car parking. So we see before and after. Before, we have a predominance of car parks. Cars are everywhere, which makes other uses difficult. And then we have a neighborhood walk, something that is peaceful, with 50% promotion of active transport and 50% permeable spaces. Another street, Avenue du 23 Novembre in Schiltigheim, we had an unequal distribution of street space in favor of the car. And then afterwards, we have a school street given over to active mobility. We see that trees have been planted. This is a real challenge to plant trees in the city, because we have underground networks, gas, water, electricity ducts, and we cannot plant them anywhere. We have to allocate at least 2 meters under the ground to plant a tree. Then we have a third example in Mittelhausbergen. Before we had a mineral lane, a wide carriageway, and then we have a planted walkway to the hills, and the small symbol on the right-hand side, it's that it is a cyclable street where bikes have priority over cars. Sometimes it generates a lot of fears from bikers, because the cars are actually driving at the toes of the bikers. But this was an experiment that was made in Strasbourg to better share public space. So lessons from the case studies. Valérie, you didn't even need to show me. Am I on time? May I spend some time on the conclusion? Yeah? So underground networks, as said, are a stumbling block to tree planting. Some local activities are saying we are going to plant 1 million trees, but we can't plant them everywhere. In parks, it has less interest in terms of ecosystem provision, because we have to take into account underground networks that are very important. So tree planting is useful for health, for physical fitness, to reduce heat islets, as we could see when there's too much heat. When we have planted areas, we can reduce by 5% the temperature during an important heat episode. And what also is important is mental health as well, because this has an impact. It has been proved that the lack of green areas could induce stress, anxiety, and depression. This is why we talk about the law of the 3, 30, and 300, 3 trees in the immediate vicinity of one's window. 30 is to go from 26 to 30 of canopia, and also afterwards is to have a green area less than 300 meters away. So the car parking is also an obstacle to the implementation of local green networks. That's an important controversy. The municipality the surface area for car parking. They also increased the fees, and that created a lot of resistance. A lot of car parks was suppressed, were cancelled, and that triggered a lot of unsatisfaction in Barcelona. They considered that cars were a source of social spatial injustice, but we very much like our cars in cities. But if we want to improve health, we have to find solutions, because it was said by my colleague earlier, we need to promote cycling paths that are secure, that are clean. We need safe lanes, but we need to plant more trees as well. So we have said that we need to have a modal shift by improving pedestrian and cycle routes. The pricing policy, we need to optimize existing car parks, but also fees. We need to optimize existing car parks, as I said, namely to pool private car parks and information technologies, like a hotel. If they have a car park that is not full, they should have an app to make sure that we can actually park our cars in that car park dedicated to the hotel. We want to create 4 relay car parks as well, to free some space, to release some space for some tramway lanes, and there will be less car parks. And if the public users were to walk 500 meters to reach their cars, then they would tend to use their car less, especially for commuting purposes, and also for green adjacent areas. We need to reshuffle the traffic directions. That requires a whole engineering path. And I have finished. Thank you for your attention. Do we have any questions or reactions? May I ask a question? Obviously, yes, sure. Thank you. Thank you for your presentation. That shows all the measures, the important measures that we should implement for health purposes. You showed well what we need to do. The question is the following, because we talked about the before, but the after is more in the pipeline. What about the reactions? You talked about the reactions to the reduction of car parks. Did we have negative reactions only to car park reduction? But when we have a structuring road and we have to change the layout where cars are no longer have priority, and there are a lot of bikes going through. We've seen this in other regions in France and elsewhere in the world. There are a lot of reactions. What is happening in Strasbourg on that point? Well, that's a very good question. As urban planning agency, we need to be forward-looking to give a long-term vision over 30 years. The reshuffling and the new layout of roads is part and parcel of an urban planning project, depending upon the deterioration of the cities. We see that as an opportunity, and we change the spatial layout in the public space. The other reaction was regarding car parks. That's an important controversy. That's a constraint. And also the investment cost. We are going through a stage where we had a lot of structural works that were quite significant. It was quite heavy. In the illustrations you can see it. But we can also imagine to have something more progressive, something more staggered with citizen involvement. We have something that is called Strasbourg Ça Pousse, where we have committed citizens aiming at greening areas to plant trees and flowers. The municipality of Strasbourg will fund the works, but the citizen that is highly involved will commit to maintaining and water these green areas. That's the feedback we could get. But then again, we need to have strong political support and vision to roll out that type of concept over the long term. Thank you. I have a second question that does not concern diet and physical activity, but that's another important component of health. It's actually noise and good sleep during the night. Do we have neighborhoods where noise nuisances are being taken into consideration, where 30 km/h is a speed limit that is being imposed everywhere? That was part of the mandate, is to go from 50 to 30 km/h in terms of speed limit in highways. They mostly drive at 30 km/h. They do not drive at 50 km/h. But that has been the subject of a lot of reflections in terms of noise, discomfort, and nuisances. When we have a structuring road, such as the one we mentioned earlier, Avenue du Rhin, for instance, that is very polluted, very noisy, there is a project to go from a 2 lanes to 2 times 3 lanes. And we'll have a tramway, public transportation that will reshuffle and make a facelift and change also the noise discomfort that we can have. As for this as for the speed limit at night of 30 km/h, that is indeed very interesting. Thank you. I wanted to know if when projects are being validated, are there some measures that are taken before and after in terms of environmental exposure, health data as actual figures or perceived data? And did you think about gentrification risk reduction? Well, for the moment, the cases that we showed is a forward-looking project. The urban planning agency, that is ours, is working as in complementarity with the Metropole agency, the urban planning unit, which has an agenda which has so much work, and they need to think short-term. Everything is submitted to environmental assessment, where indeed the impact of the project, even if the impact is virtuous, it's positive, an analysis is carried out nonetheless. As for the gentrification that such a layout could entail, well, honestly, we haven't thought about it. We're quite vigilant about the layout we use to have benches, for instance, because we thought that was very important for the elderly. But besides that, we didn't think that it was an important issue as such. Maybe thanks to you, we'll think about it, but it never came to our mind as a strong issue, as an important issue. Thank you. We'll now have Myriam Weber, who's a political advisor in urban health in Utrecht.
Thank you. I'm happy to be here and sort of honor or challenge to have the final presentation after 2 really inspiring days. Indeed, I would like to share with you the story of Utrecht about healthy urban living for everyone. As you might know, Utrecht is a city in the middle of the Netherlands. We are crossed by many railway tracks and by highways, and we are the 4th largest city in the Netherlands with almost 400,000 inhabitants. The city is very popular with students, with higher educated employees, and is growing really rapidly. We're the relatively fastest growing city in the Netherlands. And so within 15 years, our population will increase with 20%. And you can imagine that poses quite a lot of challenges to us as a municipal government, because it's not only building additional houses, like 60,000 new houses that need to be built, affordable houses, but it means we have to create jobs as well. And we have this high pressure on our public space as we want to build in through infill instead of expanding our city boundaries. And with the climate change, the shifts towards sustainable mobility, the energy crisis, this all has a lot of challenges we are facing. And that was one of the reasons that our local government already 10 years ago decided to focus on healthy urban living for everyone. This political decision has been taken by the local government, well, 10 years ago, and is still the current practice of our current local government that had been elected last year. And as you know, political terms are short terms. It's only for 4 years in the Netherlands. So politicians come and they go, which might mean that an ambition formulated 10 years ago might be completely different from the new local government decisions. And that's quite difficult for us as civil servants to work with. But what we have been doing, and with support of the politicians, is to translate these ambitions into long-term, long-year strategies and policies. And 2 policies I would like to address in my speech are the spatial planning strategy for 2040, which is indeed, like spatial planning, always a little bit further ahead, and our public health policy plans, which is a legal obligation in the Netherlands that cities have to draft a public health policy plan every 4 years. So health prevention and promotion at a city level are addressed through the spatial planning strategy. And in the process of developing this strategy for 2040 and our mobility plan, which is a part of our spatial planning strategy, we asked ourselves, what if every resident is able to find everything he or she needs in daily life is accessible within 10 minutes walking or biking, such as, and we heard it before this afternoon, grocery shops, leisure, culture, green space, schools, sporting facilities, etc., etc., etc. And you see it here depicted in a picture of illustrating healthy urban living for everyone. Because we are convinced that if we can design our city in this way, we can provide a healthy and inclusive city. Whilst developing this strategy, we came up with what we call the barcode. The barcode is comprised of all these elements that contribute to this healthy city. So to be a 10-minute city, a healthy city, every development we have has a spatial demand in square meters for leisure, for green, for culture, for sports activities, for schools, etc. And this barcode shows this relationship. So you can imagine when we are developing a new neighborhood, for example, currently in nearby our old city center, we had an industrial zone, which is now completely turned into one of the newer and very unique neighborhoods, in which we will have houses for around 10,000 people. And whilst designing this neighborhood, we take into account the barcode. So this should be a neighborhood where public space is green, is climate adaptive, where people have their shops really nearby, but where we have cultural activities and the schools, etc. And as the space is not that big, we needed to be really creative and inventive. So this will be a neighborhood where people will have no cars. So there will be a parking space below the houses, but it's only for a few cars. And most people will have the opportunity to use a car, shared mobility, which is placed outside of this area. We will have very unique, inventive storage ways and deliveries just at hubs around the neighborhood, so that within the neighborhood, every space that is left is for green, for social interaction, for sports, for recreational activities. So this is a complete new idea of designing your cities. This barcode, though, has also been used not only for new developments, but looking at our outline of the plan of the city as well. For example, when we consider play areas for children, considering the different life ages, the ages of the children, the smaller ones need to have a playground which has particular characteristics, which should be within even less than 10 minutes than when we look at adolescents which would like to have their hangout places within 10 minutes of biking. And by using this concept of the proximity, accessibility, and the specific ages of the children, we mapped out throughout the city. We did an inventory of what kind of places, playgrounds do we have? Does this meet our criteria for accessibility and the nearbyness? And then identified where we see spots and neighborhoods where we need to add or change these playgrounds. So this barcode and this perspective of 10-minute cities is really helpful in designing and changing our city. And I will give some examples later on. The other strategic and highly political and policy plan is on public health. And I just have here two recent examples. The first one on the left-hand side is the public health policy plan for the period of 2015 and 2018, where we introduced the concept of building a healthy future, so forward-looking and the health in all policies approach. So health is a topic in all our policy domains. It's not only the plan for the Department of Public Health where I am working, it's a plan for the whole municipality. So you see here as the main topics, the physical living environment and the food environment, but also the social living environment, social work, social welfare, as well as economic development and a safety net for vulnerable inhabitants. That plan has been succeeded by the current plan, which is now in its last year, which is called Health for Everyone. We made a shift from health in all policies to health equity in all policies, meaning that as a guiding principle that we want to commit to equal opportunities. We want to address health inequalities throughout the city. And we are doing so by having the key priorities on healthy lifestyles, the first 1,000 days, healthy aging, the healthy living environment, of course, and mental health as one of the new topics. To give you some examples, and this is the before and after, but the after has been already realized. This is a picture of one of the streets in our city center where we had, as you can see, quite a lot of cars and cars parking. And what we did is that we took out the parking lots and changed very easily the road into broader pedestrian walks and a shared space for cars and bikes. And what you now can see today is that people are walking all over, and we find hardly any cars because people enjoy being there, and cars experienced, particularly as we introduced our low emission zone for the city center, increased indeed. Parking tariffs, people don't come by car anymore to the city center. They come by bus, by train, by bike, or by foot. And shop owners were a little bit hesitant or even against the plans, but after they saw the examples of, for example, this street, shop owners of next streets came to our local government and asked, maybe please have a similar change to our street because we see we have more customers than we had before. Another great example that we are really proud of is this 6-lane motorway. In the 1970s and 1980s, we all wanted to drive by our cars, and we wanted to go right into the city center and park nearby to the shops to go shopping. Where we had a medieval mode that had been turned into this 6-lane motorway, which sort of ended in the middle of the city as well. So it was a strange motorway. By the 1990s and in 2000, more and more Utrecht inhabitants asked to turn this back into a really nice water area and a green area. So in 2021, a decade-long project of turning this 6-lane motorway in the middle of our city into a waterway and a park, and now we have a whole circle around the old city center, has been finished. And you see everyone is enjoying it. We are using the water for recreation, for supping and for kayaking and small boats, to walk, to exercise, to run, to meet, to socialize. And it's a perfect round for a lot of people during the lunch break to just go out, have the lunch together and have a nice walk. When we're talking about health inequalities, one of the reasons for our politicians around 10 years ago to start addressing health through all the other policy domains was that based upon our public health monitoring, we could show that we see large differences in neighborhoods, in life expectancy, and in living in good health, in perceived good health. And that was a first warning and a reason to start a political discussion about, is this what we want to see? That between two neighborhoods we see a difference in 12 years. That's not what we want to accept. We have been, of course, collecting data since then, and our public health policy plan is informed by these data collections. Last year, we published two specific reports on health inequalities, and what we found is that we see a lot of underlying causes for these inequalities coming, and you see that in healthcare, in income, in social welfare, employment, working conditions, where you know the stories. And when we look into the specific groups, we particularly saw the inequalities between men and women, of course, age groups, educational levels, yes, we know that, migration backgrounds, and neighborhoods. We used the WHO Health Equity Status Report and support from WHO to do this analysis. So this is an example of the key indicator of self-reported health, and we see that very stable inequalities in self-perceived health between the educational groups between 2012 and 2020. In order to address these health inequalities, I would like to share a few examples, which this one is about social renovation. As you know, we all have to make this transition to address climate change and energy poverty. So what we are currently doing is renovating a lot of social housing apartments. And instead of just focusing on the physical renovation of the flats, we introduced the social part as well. So people, before we start renovating, get a visit from social welfare, from the neighborhood professionals to talk about the situation at home, at their homes, whether they have particular health needs, whether they have income problems, whether they experience stress, etc., etc. And so we can form a whole network around the people in not only providing them retrofitted and energy neutral houses, but addressing other topics like education and income and, for example, raising their children as well. We have recently evaluated this first project in one of the areas in the Nigerdreef. And what we saw is that we see an increase in appreciation of the house because there's less noise, annoyance, odor, and moist. But we see a decrease of perceived health, particularly mental health, sleep quality, and control, part of which might be due to the corona crisis, the current crisis due to the energy prices and Ukraine war. But we really have to look into this. And one of the reasons for this decrease of perceived health might be that almost half of the residents experience stress due to the renovation. So this is something really to take into account, that although we aim to do good, particularly in these groups where we see particularly a lot of people with a migrant background and lower socioeconomic status, they are more sensitive to stress when things are changing in their daily lives. When we want to address these inequalities, we focus on specific neighborhoods. This example of social renovation is in one of the most deprived areas in Utrecht, where we saw this 12 years lower outcomes in good health. So what we are doing, for example, in this picture is that we have, of course, a lot of partner organizations being active in these neighborhoods as well. It's not only our work as municipalities. And for example, organizations focusing on well-being, cooperating very closely with the sports organizations that offer sports programs for more vulnerable groups. And citizens with a low income can get a recycled bike almost for free and get classes on how to ride a bike safely. Well, we do focus on specific groups as well. Oh, this picture is only half. You would have seen on the right, but it's on the left as well, our vice mayor on public health. Because we're focusing, like I said, on specific groups, on specific vulnerable groups. For example, in the program which is translated in Healthy Weight at School, which has a broad selection of physical activities, education and parent involvement in many schools in Utrecht. And what we now added since last year is the Healthy School Lunch, which is not quite normal in the Netherlands, that you have lunch at school. Children, when they stay over at school, bring their own lunches, but it's not provided by the schools. And with this program, we are introducing this, that we organize together with schools and food providers a very healthy vegetarian lunch, local produce, and including sport activities and lessons on healthy diets. And enthusiasming the children to start cooking and bring that back home as well. So where does it bring us?
Excuse me.
Yeah, I'm wrapping up. Yeah. So this is our public health model, where you can see that we are addressing far more criteria than just the single target ones and a lot of projects. And particularly when we're talking about unequal investment for equal opportunities. So making a key out of thinking of what is particularly needed when we talk about health inequalities. So this is my last sheet. This will be our public health policy plan starting next year. We are drafting it. It's not approved yet. It will be at the local government and the council in September and October, with the aim of reducing health inequalities in Utrecht between the lowest and highest socioeconomic groups by 30% in 2040 compared to 2012. And we do so by indeed addressing the social economic factors by strengthening the society through the living environment, healthy behavior, and mental health. So thank you for your attention, and I would like to invite you, if you would be willing to or have the opportunity, from the 21st to the 23rd of November, we will be hosting the WHO European Healthy Cities Network Conference in Utrecht. So when you fancy to see what is going on with site visits and presentations, you are kindly invited. Thanks.
Merci énormément pour cette présentation qui est à la fois conclue.
Thank you very much for this presentation, which is a fitting conclusion for this session. It opens new vistas. We could listen to you for hours. It was very inspirational indeed. Any questions? Can I ask one? Yes. So we have one question here in Paris, and then over to you. Yes. Yes, thank you very much for this presentation. What you said was very interesting, and particularly, so if I got it right, 50% of people who felt stressed out because of the renovation of their neighborhood and their flat. It's something that's actually been identified repeatedly. People are happy because their home is cleaner, etc. But all of a sudden, I mean, it's such an abrupt change that it can cause stress. And you said that authorities should be mindful of that. And I think that community-based initiatives, so the direct involvement of people in the renovation process is something important. Because all of a sudden, the world that people were used to, even though it wasn't a great world, even if it becomes better, people can feel very vulnerable. I can feel vulnerable. I mean, I say I because I've been through this. I've experienced this. So human beings are complex, as we've said in the last 2 days. And it's very interesting that you pointed this out. Thank you very much for that.
Jean, vas-y.
Yes, thank you very much for your very stimulating presentation with examples also before, after already implemented, which is also the vision of the reality. And you speak about the vision of 10-minute city, and if I well understood, this is the target for 2040, isn't it?
Yes, that's correct. So this is indeed something. Of course, in certain places we have that in place, but it's indeed the vision for 2040, and
But what is the original situation? I mean, now in 2023, or at the beginning of when the decision to make such a policy was taken in 2013. What is exactly the figure of the percent of the population which already in the 10 minutes city?
I don't know the percentages, but to give you some examples, for like model split, around half of the people go by bike to their neighborhoods, and we have quite a lot of nodes for public transportation, which is really great. So I think for certain topics like schools and recreational areas, we meet already the 10 minutes criteria. But when we talk about cultural activities, for example, there we see that we have to invest more and to have more facilities or services within particular neighborhoods. And I myself am living in one of the newer neighborhoods, so I see there it's all well organized. But you see, particularly in older neighborhoods, there is a need to rethink some of these services and their availability of that. But I think in general, and of course, Utrecht is not that big, so going from one side to the other side is only 12 kilometers. So it's assumed that you will be there in 10 minutes.
Well, I think that the grid presented for Strasbourg will be very useful also for Utrecht.
Yeah.
Because it's a very useful tool to
yeah. Yeah, we certainly will have a look in that. Thank you.
And perhaps in the other sense, the 6-lane highway transformed will be a good example for the city of Strasbourg, for the now where is the contournement west de Strasbourg, to make the former highway in the Waterlane, perhaps.
Yeah, indeed.
Est-ce que, voilà, bon, l'heure est passée, mais si certains d'entre vous souhaitaient encore poser une question,
any of you wishes to ask a question as a follow-up of everything that has been said this afternoon, do not hesitate, even though
oui, madame.
We should have wrapped up. Yes, ma'am.
Oui, oui. Bonjour.
Hello.
J'ai bien apprécié toutes les présentations.
I really liked all the presentations.
Je voudrais savoir si
I would like to know
les usagers ont une place privilégiée
What
dans
about public
la
service users?
réflexion, l'élaboration et
Are
l'évaluation
they involved
de
in the
toutes
reflection, the
ces
assessment
actions qui sont menées
of all the
pour,
actions that are
avoir,
being carried out
des infrastructures qui favorisent
regarding
la santé?
infrastructures
Est-ce que
for health
sont vraiment tous les
purposes?
usagers sont impliqués dans la
Are
réflexion?
public users, public service users, all involved in the process?
Je peux donner un élément de réponse sur
I
les
can
pratiques de
give
vélo, notamment
part of an answer
sur
regarding
les
bikes.
infrastructures vélo, les
On
associations
bike
d'usagers
infrastructures,
de vélo
user
sont pas seulement impliquées, c'est vraiment
infrastructures
elles qui sont motrices.
are not
Sur les
only
politiques qui,
involved, they're
s'investissent,
actually
qui
the
font vraiment des
drivers,
plaidoyers
they
à
are
toutes les
at the
échelles,
origin of
mais aussi et
everything,
surtout aux échelles locales.
especially at local
C'est pas
levels.
toujours dans une perspective santé, mais en tout cas là,
It's
on a
not
des,
always
on
for
a
health
peu
purposes,
d'exemples,
but we have few
d'associations
examples
d'usagers
of
qui ont
us,
autant de
of
maîtrise
user,
technique, à la
of
fois
user
sur l'aspect
associations who
et,
have so much
autant
technical knowledge
de force de plaidoyer, je dirais,
and
dans beaucoup de
force
petites
of
villes,
will
c'est
in
vraiment,
advocacy
les interlocuteurs vers lesquels les municipalités se tournent
subjects.
pour
This is
même régler les aspects techniques
how it
d'aménagement,
works. The
d'aménagement.
public authorities, the local authorities turn towards the user associations to design their policies and measures.
Là, c'était les usagers de transport, pas forcément
We
les
were
usagers
talking
santé,
about
effectivement, ouais.
transportation users. We're not talking about health users here, of
Parce que
course,
l'intitulé
healthcare
de
users.
notre
Because the title of the workshop is environmental policies and public health in territories, preserving the health of today and tomorrow's generations. So, are these generations involved? Are they defined only by the institutions? Or do we always have a group, a workshop that includes generations? I know that some cities, local authorities set up elderly committees, young people committees to participate, to give their input on the design of these measures. What you're pointing out is the principle of participatory approach. May it be at the level of local authorities, institutions. I'm talking about Santé Publique France, for instance. More and more, we are mindful of that. This is what we do. We do it. We want to do it for and with people and not against people. So obviously, this is part and parcel of the way we tackle subjects. And this is the approach we are adopting now. Because as you're pointing out rightfully, users have sometimes been neglected. And this is something that transpires everywhere, especially for local municipal councils. Projects are being set up upstream with users. It's not everywhere, but it's more and more widespread. If I may follow up on this, we have the example of Camellia, which is a very good example of community participation. This is done through a network of associations. And that is also the case for the concept of healthy city. This is really at the forefront of this approach, and the stage 7 of the European network mentioned this participation of the community, and this is why I would like to give the floor to the president of the French region, because he certainly can give his input, but also talk about the next stage, because it will finish next year. Do we have any indications as to which priorities will be set for the years to come? Thank you, Jean.
J'aurais bien voulu
Indeed,
aussi réagir
I would have liked to react on the subject as well.
Bougent,
there are a lot of things moving the lines right now, but we're far from full involvement. Saying that now,
la participation des habitants
inhabitants' participation and civil society stakeholders is not the icing on the cake, but it's actually an essential part of the success of a project.
sur beaucoup de politiques de
This
manière
idea
générale.
has been widespread everywhere
Je sais que c'est le cas
recently. I know
en
that this
matière de
is the
santé, mais
case
je
in
pense
matters
avec
of
encore
healthcare, but maybe
un peu de handicap parce qu'on
there
a
are
quand même
stumbling
culturellement,
blocks because
en tout cas dans
culturally,
notre pays
in
particulièrement,
our
une
country
approche
especially,
de la
our
santé qui est quand même
approach of
très
healthcare
descendante,
is very
avec une
that
conception de
of
l'expertise détenue par les professionnels. Et moi, je crois que
a downward
l'expertise
approach.
Scientifique, l'expertise médicale et l'expertise
And the scientific,
professionnelle,
medical and
elle ne
professional
ressortira
expertise
que plus grandie et
will
avec plus
grow
d'autorité
and have
qu'on
more
la mettra
authority
dans un
if
dialogue
we
avec
insert it
l'expertise
in
des
a dialogue
patients,
with
des usagers,
patients,
des
users,
habitants de manière
inhabitants
générale.
in a
Les
general
démarches
way,
de promotion et de prévention de la santé, on
promotion
le sait, en
and
France, on a du
health
retard
promotion
sur la question. On a une
campaigns.
opportunité
We are
avec ce qu'on
lagging
connaît
behind
aujourd'hui
on this subject.
sur
We've
les
seen it.
déficits en matière
We've also
d'offres
seen our deficit in
de
terms of
soins,
offer
de
of
déficits sur les professionnels de
healthcare
la santé,
services and
d'opérer un
deficit
virage. Non pas pour se dire qu'il n'y a pas de
we have
problème
lacking
sur la
health
question
professionals, so we can't say that there's no problem in
l'accessibilité aux
terms of
professionnels
accessibility
de
to
santé et leur nom,
healthcare
mais pour se dire
professionals.
qu'on a aussi
But
à
we can
investir
say
très fortement ces
that
sujets-là.
we
Et
have
par exemple, sur les
worked
sujets
very
de
much on this
médiation en
subject.
santé,
Same
aujourd'hui,
thing
on n'a
in
pas de
terms of
statut
mediation.
clair sur qui sont les médiateurs
We do
en santé.
not
Or,
have any
c'est
straightforward
des
tools
professionnels
to
dont
know
on a
who are the
besoin,
mediators.
pour
We
lesquels
need them, however.
le fait d'avoir l'organisation
Having an
par CPTS pour
organization
les
by
professionnels de santé privés
CBTS
sur les
for
territoires
the
est
private
justement une
healthcare
chance pour faire le lien
services, that's
avec les
actually
villes
an
et
opportunity
avec
to have
les habitants. Il faut qu'on l'investisse.
bridge
Et d'autant
between
plus qu'on le sait,
inhabitants
c'est des
and
professionnels qui
the
sont aussi des supports
healthcare
de réussite
establishments.
pour
That is a key
l'action
for
par les pairs,
success
qui
for
elle
peer
aussi est un
support
levier
as well. This is also a
important.
driver
Donc,
that is
effectivement, il y a beaucoup
important.
de lignes qui bougent
We
dans
are
le
moving
bon
the
sens, mais
lines
je crois qu'on
in
n'est
the
pas
right
encore
direction,
au bout du
but we
chemin, parce qu'on
haven't
a un changement
crossed the
culturel
finish line
à
yet.
opérer pour que les habitants soient
The
eux-mêmes aussi
inhabitants
acteurs
need
de
to
leur santé. On
be
a tous à y gagner.
full-fledged actors of the project. We will benefit from it, undoubtedly.
Eh bien,
Okay.
il ne me reste plus qu'à remercier une nouvelle fois l'ensemble de nos intervenants. Merci beaucoup pour tous les éclairages différents que vous nous avez apportés cet après-midi. Et si vous avez encore un peu d'énergie, j'aimerais bien qu'on puisse les applaudir.
I would like a round of applause, a vibrant round of applause for everyone.
Jean à Genève, est-ce que tu
Jean in
veux
Geneva,
donner un petit mot de la fin?
would you like to say a few words as a wrap-up? Well, I said it already. I think that
notamment que les 6 présentations étaient toutes
the 6
très
presentations
intéressantes, mais
were
surtout
all
qu'on a
very
vu
interesting.
qu'au fur et à mesure, on avait des réponses aux questions qui étaient posées. Par exemple, la première question qui concernait les obstacles pour les
we
vélos
saw all the answers
ville,
to all the questions that we asked ourselves, such as the bikes, as an answer to the stumbling blocks in terms of urban planning, but also the other layouts in Strasbourg for meeting spaces, so we can have something more flexible rather than going from a cycling path that would be more burdensome to have mixed zones. This, we could have 20 km/h speed limit with pedestrians and bikes, but there are elements of answer that we found throughout the different presentations. I underlined also what was said from GABA-RS, what we should do for health-friendly urban planning. What is important is also being acquainted with the stakeholders and make sure that the stakeholders understand what we mean by health. Health, as a majority of our population understands it, that's important. But also strong political support, that's very important via tools. It hasn't been mentioned much, but this can be done between a region and a town, and that has been done via local councils, for instance.
Merci.
Thank you.
Merci à vous.
Thank you to all of you.
Au revoir.
And goodbye.